PodcastRx.
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 Welcome to PodcastRx from Diamond Pharmacy, a show featuring the pharmacists and personnel behind the nation's largest correctional pharmacy provider. While we talk primarily about clinical and regulatory topics affecting the institutional healthcare clients we serve, we'll also occasionally get into the stories behind the people moving our company forward. This isn't just a pharmacy podcast, and you don't have to be a clinician or a pharmacist to enjoy it. For this final episode of 2023, we welcome back regular contributor Chris Bender from the Optics Clinical team to pick up our conversation about GLP-1 weight loss medications. With the FDA approval of Zepbound, or Tirzepatide, for weight loss in November, the profile of these potent and high-profile medications only continues to rise. We take a look at Tirzepatide, how it compares to semaglutide, what the clinical data shows for its potency, and what promise it shows for obese and overweight patients. We also discuss some exciting new weight loss medications in development and what all this new drug development and approval could mean for the future of bariatric surgery. All these topics and more on PodcastRx. I'm Adam Campbell. Hello, Chris Bender. It's good to have you back on PodcastRx as always. How are you today?
Oh, hey, good morning, Adam. I'm doing well. Hopefully you are as well. It's always a really nice day whenever I get to chat with you. It's always good to be back on the pod.
Absolutely, and always good to have you. And you know, Chris, we were reminiscing before we started recording here that just about a year ago, if you can believe it, we recorded an episode devoted to GLP-1 agonists and weight loss with a focus on semaglutide in particular. We were looking at how GLP-1 agonists like Ozempic and Wegovy were not only effective at weight loss and diabetes management, but also having a bit of a cultural moment as social media influencers and celebrities were swearing by these drugs and helping to drive demand and shortages of those drugs, even if maybe those celebrities might have been using them in an off-label fashion, but that's a different conversation. Either way, medications like Ozempic, like Wegovy, were essentially a phenomenon and really continue to be. Almost a year after our discussion, we're seeing the profile of weight loss drugs continue to grow with the FDA approval of Zepbound on November 8th. Zepbound, which I can't help but think is a terrific name that either conjures up visions of airship travel or going to see Led Zeppelin, is a trade name for Tirzepatide, which unlike semaglutide is a dual-acting GLP-1 and GIP receptor agonist. More on that in a bit. It is a once-weekly injection, and the dosage must be increased over 4 to 20 weeks to achieve the target dosages of 5 milligrams, 10 milligrams, or 15 milligrams once weekly. Maximum dosage of Zepbound is 15 milligrams once weekly. Tirzepatide was first approved by the FDA in 2022 as Mounjaro and used to reduce blood sugar in people with type 2 diabetes. Zepbound is the version of Tirzepatide specifically approved for weight loss in obese patients. With Tirzepatide showing improved weight loss numbers over semaglutide in clinical trials, it's entirely possible that Tirzepatide will be a phenomenon of its own. So, Chris, with this recent approval of Zepbound, I wanted to keep our conversation going about these weight loss agents and get a sense for both the basics of how they work and what kind of impact they'll continue to have moving forward. So to start, as we often do, and what I know you like to do, let's build up from the basics. How exactly does Tirzepatide work for weight loss in contrast with semaglutide?
Yeah, so first, fantastic introduction, Adam, as always. So I'm excited to get into this topic with you and revisit it today. So Tirzepatide actually works exactly the same as semaglutide when it comes to weight loss. Both drugs activate the glucagon-like peptide 1 receptor, or GLP-1 receptor for short. When the GLP-1 receptor is activated, the body more effectively produces insulin in response to food intake. It also decreases the body's own production of glucose, which eventually goes on to become blood sugar. It slows down the GI tract, so food stays in the gut for longer, and it increases our feelings of satiety, or in other words, feeling full. It's these latter two that are responsible for the weight loss effects of these medications. Namely, they slow down the gut and they make you feel fuller for longer, effectively decreasing one's overall food intake. Now, in addition to activating the GLP-1 receptor, Tirzepatide also activates the GIP receptor, which doesn't have any additive effects from a weight perspective. However, it does provide additive effects with regard to insulin secretion. So from a diabetes perspective, this dual mechanism provides additive benefits when it comes to glucose control. Now, additionally, GIP activation acts almost as a safety mechanism in the fact that when blood sugar goes too low, GIP can actually stimulate glucagon, which in turn can raise blood sugar levels. So the dual mechanism of tirzepatide makes it not only more effective for blood sugar lowering, but also somewhat protective from going too low, which is nice.
Who exactly is Zepbound approved for? I would assume it's very much the same as Wegovy.
It is. So Zepbound is approved for adult patients who are either obese, which FYI is a BMI of 30 or greater, or overweight individuals, which is a BMI of 27 or greater, who have at least one weight-related condition, so such as cardiovascular disease, dyslipidemia, hypertension, obstructive sleep apnea, or type 2 diabetes. So, like I said, this is the same criteria that we see with existing weight loss medications. And I should say, I would just like to delineate that there's essentially two buckets of individuals who this is approved for. You can either get this medication if you are obese, flat out, or if you are overweight, you must have one of those weight-related conditions. So given the increasing prevalence of, both obesity as well as those chronic conditions, I think it's pretty reasonable to believe that Zepbound, among others in this category, are applicable to a pretty broad swath of the U.S. population.
Something that I misunderstood when I was researching these initially, I thought Zepbound and its counterpart, Mounjaro, Zepbound was the higher dose version of that, but that's not the case, right?
Right, and that was actually interesting to me as well, because we saw that construct with Saxenda, which is liraglutide, and Wegovy, which is semaglutide. Those weight loss medications were both approved for weight loss at a higher dose than what they were approved for their diabetes indications. With the Mounjaro and Zepbound pairing, they're actually they're approved. The Mounjaro is approved for diabetes and Zepbound is approved for weight loss, both at the same dosing. So that was a very interesting dynamic to see in comparison.
Is there any reason behind that in particular? Because the other two are clearly different higher dose versus lower dose versions. Is there any other reasoning behind that?
Honestly, from my reading of it all, it just basically comes down to the fact that it appears that tirzepatide is somewhat more potent than semaglutide and liraglutide. So it simply didn't need to be given at a higher dose. Like the doses that they were using for diabetes were already potent enough that they didn't need to kind of dial the knob up anymore for additional weight loss effect.
Well, you mentioned potency. Tirzepatide is more potent than semaglutide. What is the clinical data shown in terms of this potency, weight loss efficacy, everything? How does this compare to what's come before?
Right. So there was actually a major clinical trial published last summer that showed the robust effects of tirzepatide when it was used for weight loss. In this trial, the average weight loss was 31.5 to 53.7 pounds. Obviously, this depended on the dose of the medication, with the vast majority of participants losing at least 5% of their baseline weight, which is something of a gold standard marker to demonstrate individuals' response to any weight loss medication. Now, a weight loss of 31 to 53 pounds is obviously fairly substantial. This equates to a 15 to 21% reduction in the participants' baseline body weight. So we're talking about losing up to a fifth of your body weight, potentially, when using Zepbound. Now, the next closest comparator is obviously Wegovy, which demonstrated an average weight loss of 22 to 27 pounds, again, depending on the dose that was used, with the majority of participants losing at least 5% of their baseline weight. Now, what's important to highlight here is that the trial for Zepbound was slightly longer than typical trials for weight loss drugs. So it was 72 weeks versus 52 weeks, which is more of your traditional trial duration for weight loss drugs. So in that sense, yes, the numbers for the weight loss numbers for Zepbound may be somewhat inflated. But I will note that when I looked at the data, the majority of the weight loss was actually attained by week 52. So it does seem as though, like we said before, it does seem as though Zepbound is the more potent of the two. Now, the other GLP-1 agonist, as I mentioned, Saxenda, demonstrated less weight loss. So it was the lesser of the three GLP products currently available. It demonstrates average weight loss of 8 to 11.4 pounds over 52 weeks, with only about half of participants losing at least 5% of their baseline weight. Now, these numbers are somewhat more comparable to what we see with the oral treatment options, of which there are many. But they're just as important to review because in some cases, insurances may require a trial of oral therapy prior to injectable therapy simply because of the lower cost associated with these oral therapies. So to review, we have diethylpropion, which sort of a cousin of the antidepressant bupropion or Wellbutrin. Honestly, it's an older drug and it's not super commonly used. We have phentermine, which is somewhat commonly used. It's been in use for over 60 years. We do have a newer combination which pairs phentermine with topiramate, which is a seizure medication sold under the brand name Qsymia. We have a combination of naltrexone, which of course is a drug used to treat opioid and alcohol use disorder, combined with bupropion. Again, like I said, is an antidepressant sold under the brand name Contrave. We have orlistat sold under the brand name Xenical, which interesting about this one is it basically prevents fat absorption in the gut. And then finally, we have Plenity, which might be the most interesting because it's not actually a drug at all. So it simply absorbs water in the gut and it expands in the gut, which ultimately creates a sense of fullness, which is what we're looking for. And with most of these oral medications, you're looking at a weight loss of somewhere around 10 pounds over the course of the year, although Qsymia actually demonstrated a little bit higher with a weight loss of up to 19 pounds in its clinical trial, which is a bit closer to that seen with Wegovy.
You know, Chris, despite all the impressive numbers and comparisons of effectiveness down the line, it's important to keep in mind the impact of the non-pharmacologic factors in the overall success of these medications. That is, they need to be combined with a healthy diet, exercise, and lifestyle overall.
Yeah, I don't think that can be stressed enough. And just an interesting tidbit, kind of, getting into the clinical trial weedsiness of it all. That's why you see higher weight loss in the weight loss trials as opposed to the diabetes trials. Because, for example, when we were looking at, not we as in me personally, but, when in the clinical trials that assessed Mounjaro, for example, for diabetes, the weight loss was prominent, obviously, but it wasn't as robust as what was seen in the Zepbound trials. And as we said before, the doses of those two products are the same. So what you have to remember is in the weight loss trials, those patients participants are being more closely monitored and are being encouraged to participate in lifestyle modifications. So those dietary exercise programs and whatnot. And just from that alone, that addition alone, that's why you see weight loss trials have such higher weight loss numbers than traditional diabetes trials, because they're not focusing as much on the lifestyle. They're not as intensely monitoring the lifestyle perspective. So I think that really goes a long way and is more of a long-winded way of saying hey, if you don't participate in the lifestyle stuff, you're only going to get as much as you put into it, essentially.
Right. You get what you give.
Yeah.
Yeah. Another question I had, Chris, when you're talking about the oral weight loss agents, you're seeing less weight loss overall from those versus the injectables like Zepbound, like Wegovy. Is there or do you think that the oral agents will become more powerful? That it seems like that's a more palatable way of taking these rather than a once weekly injection. What do you think to the development of that, where you start to see more of those higher numbers in an oral agent?
So that's interesting because that's obviously the most, like you said, palatable medication option. The issue with those is that they're typically limited in the fact that a lot of them work based on the fact that they simply have weight loss as a side effect. Because a lot of those medications that I listed, topiramate, bupropion, for example, those don't necessarily cause weight loss from a hormonal perspective. And obviously, when you're discussing hormonal aspects, the hormonal aspect is obviously the stronger aspect. So I don't think that there are going to be significantly stronger traditional oral medications. Now, I should hedge that by saying that there are some oral GLP-1 agonists in the pipeline, which those may ultimately come to rival these injectable ones. But again, they're still working on the hormonal pathway. So from a traditional oral medication standpoint, I think we may have squeezed out all that we could have from from that.
Gotcha. Okay. I would assume in terms of any notable side effects that Zepbound would look a lot like Wegovy. Is this accurate? Are there any new safety concerns with Zepbound?
Yeah. So that's basically correct. Because Zepbound works so similarly to Wegovy, there were no new safety concerns identified with the medication. Generally speaking, the most common adverse effects with all of the GLP-1 agonists, and in the case of Zepbound, a dual GIP/GLP-1 agonist, are namely involving the GI tract. So if you remember, these medications work by slowing down the digestive system. So abdominal pain, constipation, decreased appetite, diarrhea, nausea, and vomiting are all fairly common. Now, these medications have also been associated with rare cases of diabetic retinopathy, gallbladder disease, and pancreatitis. And finally, it's important to note that these medications should not be used in individuals with a personal or family history of certain types of tumors, specifically medullary thyroid carcinoma and multiple endocrine neoplasia syndrome type 2. But it's important to note that these are not new. These were also aware in the medical community has been aware of all of these warnings and precautions and contraindications when using the diabetes forms of these medications, which we've been using now for quite some time. So the medical community is already quite aware of these things and shouldn't be too alarming to hear.
With everything that we've mentioned about Zepbound, its potency, its efficacy, are there any other notable areas to which it stands out from the other GLP-1 agonists, the other weight loss agents on the market?
Other than its effectiveness in diabetes and weight loss, not really. I would say that it is namely it is more potent. So I guess that would just be, where it stands out from the competition. But, from a cost perspective, Zepbound may start to stand out, given that it's actually, it appears to be about $300 cheaper per month than either Wegovy or Saxenda. But as with anything, these things are always in flux and they can be subject to change based on market pressures. So got to really take that with a grain of salt.
Right. And just for reference, I did look that up before we talked. The cost of each, the list price. Zepbound is just a little over $1,000, $1,060. Wegovy is $1,349, and Saxenda is also $1,349. So, yeah, that bears out what you just said. Yep. Chris, in our previous episode, I asked you about the utilization of GLP-1 agonists in the corrections health setting. I was curious about that. You said that you were seeing increasing usage and recommendation, especially regarding diabetes treatment and the attendant cardiovascular benefits. But as far as treatment for weight loss, you said the uptake was slow, and that's perhaps to be expected. You noted that cost played a role, as did the general tendency of weight loss drugs to be slowly integrated into the community at large. A year later, have you seen any change specific to that at weight loss agents? And of course, now with a new option in the mix, do you think that speeds the uptake?
Yeah. So, I haven't necessarily noticed a change in uptake in our main areas of focus, those, of course, being corrections and nursing home. And I think that makes sense with weight loss not often being the top priority in either of these patient populations, plus with, as you had mentioned, costs being a huge concern. I think where the main increase will be seen, at least right away, is going to be in the community. And unfortunately, I can't really speak to that as much. Now, that being said, I don't think that utilization will increase simply because there is another option. I think that utilization will increase because of the effectiveness of this new option, as well as the attention, the media attention that has come with it. this is already pretty well known, but Zepbound produces results nearly to the extent seen with bariatric surgery. So we're starting to see these conversations, from a payer perspective, regarding the overall cost effectiveness and overall quality of life of this therapy versus existing surgical options. And something else that might drive the needle and may ultimately increase uptake in our areas of focus, like corrections and nursing homes, is there's actually been new research coming out, particularly with semaglutide, that shows that we knew for years that use of semaglutide had cardiovascular benefits, like you alluded to in the question, in the diabetic population. But we're now starting to see evidence of cardiovascular benefits when using just for weight loss purposes as well, which does make sense given, the cardiovascular risk that comes with, obesity as well. So I think that as the community at large becomes more aware of the cardiovascular risk reduction, both in diabetes or standalone obesity, it's going to be harder to kind of deny those therapies to those patients because of the overall cost effectiveness moving forward.
Right. As we record this, Zepbound is supposed to be available in drugstores. What I read this morning, end of 2023, but you had indicated to me before we started recording that it is showing up with wholesalers. So either way, it's going to be available very soon. Given the shortages that we saw and that we talked about with Wegovy and Ozempic in particular, do you think it's a given that we'll see a shortage of Zepbound? And just as a total side note, the holiday season is an interesting time for a weight loss medication to officially hit the shelves, given how people are so often preoccupied with weight gain around this time. That's a side note, but I thought I'd bring it up.
As with anything in the commercial or in the retail world, you always want to come out right around Christmas time. So, it's all about the stocking stuffers, Adam. So it couldn't be better timing. Now, although I don't think with the price tag as Zepbound that it's necessarily a stocking stuffer, but that's neither here nor there. Honestly, I don't think, and this is all just purely, conjecture here, but I don't think that we'll see shortages with Zepbound the way that we did with Wegovy and Ozempic. And I think that's really because, the shortages of Ozempic and Wegovy were sort of like the perfect storm. The manufacturer had production issues that happened to occur at the same time as that social media hype boom that we saw. Whereas Eli Lilly, which is the manufacturer of Mounjaro and Zepbound, they kind of have the advantage here in the fact that they're coming to market after both Ozempic and Wegovy. So they've had the opportunity to kind of take a look at that, assess the market, and they're likely going to be properly anticipating the market demand of their products.
At the risk of sounding totally trite here, these weight loss medications, they just keep getting better. Chris, are there any other agents in development that look to improve upon what Wegovy and Zepbound have started? And I should rephrase that. Of course, there likely are, but are there any agents in development that are fairly close to coming out that look to improve upon what Wegovy and Zepbound are doing?
Yeah, I mean, you hit the nail on the head. There's always things in development, no matter what area of medicine you're looking at. It's just that some are more robust than others. And this is a particular area that is particularly robust. And I'll kind of piggyback off of what you said, because it's really impressive, how they continue to just seemingly create more and more effective options one after another. But like I said, there are numerous agents in the pipeline right now that are being studied. In fact, there's a pair of dual GLP-1/glucagon agonists. So this is going to be a new class of medications compared to what is already available. These are pemvidutide and survodutide. They're being developed to actually induce weight loss and treat fatty liver disease, which is unique from what we've seen so far. Trials for these agents have demonstrated weight loss of 10% and 18%, respectively. There is also a tri-agonist of GLP-1/GIP/glucagon, known as retatrutide. in development for weight loss specifically, which has shown upwards of 24% weight loss in clinical trials. So we're talking slightly better, if not, comparable, if not better than what we see with Zepbound, which is pretty wild. Additionally, there's ongoing research into oral agents that we alluded to earlier that also work on these hormonal pathways with orforglipron and danuglipron. Both are, as I mentioned, oral GLP-1 agonists. They have thus far demonstrated potential weight loss of up to 15%. So slightly lower, possibly, than Wegovy and Zepbound. But again, like we said before, they may be the more palatable option because for the needle averse population. And the good thing about these is they may also become a prominent treatment for diabetes as well. Now, I think what's most interesting about this particular space is that we've kind of gone from drugs that were exclusive to diabetes, and then we've progressed into weight loss, and we're now progressing even further into other metabolic diseases like fatty liver. In fact, some of these agents, like pemvidutide, have shown additional benefits with regard to blood pressure and cholesterol lowering. So I think moving forward, we're kind of going to have a situation where it won't necessarily be a one size fits all, but rather we're going to have a full armamentarium of options that clinicians can choose from. And they're going to be able to tailor to each individual patient, which, at the end of the day is really what good medicine is all about.
Yes, 100%. And there's that Easter egg word again. I heard you drop it
for your bingo cards.
All right. Just to end our conversation today, a few episodes back, I spoke with your colleague in optics, Henry So, about bariatric surgery, which you did talk about a little bit in this episode. We didn't get too heavy into the relationship between the new medications and bariatric surgery, but I wanted to get your perspective, Chris. What effect do you think that these drugs like Wegovy, like Saxenda, like Zepbound will have on bariatric surgery overall? It could be easy for someone, obviously not in the medical field, to just see what these drugs are doing and just generalize it. Wow, they're just going to get better, and eventually that surgery won't be necessary someday. Might there be any truth to that?
Well, I think that in many cases, pharmacologic management will overtake bariatric surgery, at least in popularity, given that it's less invasive and it produces fewer downstream complications. Notably, we see nutritional deficiencies after many bariatric surgeries. Now, that being said, there will always be scenarios in which surgical measures reign supreme. So, for example, there are instances in which an individual may require more weight loss than a medication can provide. I mean, sure, these medications are coming close to rivaling the weight loss seen with surgery, particularly Zepbound. But at the end of the day, surgery still does provide higher degrees of weight loss. And another thing to consider is the durability of our medications to keep the weight off. Unfortunately, these medications at a certain point, they do kind of reach a plateau, and individuals can actually start to out-eat the medication, and they start regaining some weight simply because their sense of hunger kind of comes back a little bit. And additionally, as with all medications, of course, these require patients to continue taking their medications on a regular basis, which, regardless of whether it's a once daily or a once weekly, no matter how easy or simple the regimen becomes, it can still be difficult. Whereas with a surgery, it's a one and done type situation. You get it and you're done. So in settings of overcoming the medication and patients with non-adherence, I think surgery is still going to, likely be the preferred options. Now, what's interesting to think about that I've even seen some experts discussing is there may even become situations where patients, despite having surgery, may still have a small bit of weight left to lose. And I think that's where we could even see the addition of medications on top of a surgery, just for that patient to get that last little bit of weight loss to kind of push them over the line. So in all, I don't think this is going to be a situation of one truly overtaking the other, but rather it may become a situation where the two can, kind of be used in synergy, or allow for a more stratified approach for weight loss, depending on various patient factors.
And as you said just a little bit earlier, what good medicine is all about, right?
Exactly.
Yeah. Well, so many exciting developments in this space that we'll no doubt continue to watch and quite possibly, or I say likely, discuss again. Christopher Bender, thank you so much for your time. I hope you have a wonderful holiday season, and I'm sure we'll talk again in the new year.
Well, it's always a pleasure. Thank you for having me, Adam. Have a happy holiday season, and I look forward to talking about this again. And who knows, maybe next year, maybe in another year.
Yeah, for sure. Thanks, Chris. Take care.
All right, take care.
PodcastRx features conversations with healthcare professionals. The statements and opinions discussed herein are for informational purposes only. This podcast should not be considered professional medical advice and should not be used as a substitute for the advice of an appropriately qualified and licensed healthcare professional. Therefore, listeners must not rely on the statements made herein. But we do hope you enjoyed them.
PodcastRx is a production of Diamond Pharmacy Services, the nation's largest correctional pharmacy provider. Keep up with our show on all the major podcast platforms, including Apple Podcasts and Spotify. New episodes usually drop the first full week of each month. Where possible, please rate and review the show to help us reach more listeners. If you have any questions or feedback for PodcastRx, we'd love to hear it. Shoot us an email at podcastrx@diamondpharmacy.com.